In this segment of the DVD, we're going to be doing some practice cases using the Emergency Severity Index. And joining us are Pat, Linda, and Karen. So what I'm going to do is read the case, and then we'll determine what ESI level each patient is. All right? An 8-year-old is brought to triage because of an injured right ankle. The child had tripped over a ball while playing soccer. The ankle hurt with ambulation, and you notice edema over the medial aspect of the ankle. Mom tells you the child is healthy, takes no medications, and has no allergies. His vital signs are within normal limits. So do you think he meets any ESI level 1 or 2 criteria?
Definitely not. He has a sprained ankle.
Most likely he does. But let's talk about resources. How many resources is this patient going to consume?
Probably 1, just an x-ray.
We might not do an x-ray. We use the Ottawa ankle rules, at least in adults.
That's a really good point. Let's talk about resources. How many resources do you think this child's going to need? He might need an x-ray and then would meet ESI level 4 criteria.
But if this child was actually an adult and your institution used the Ottawa ankle rules and the patient did not require an x-ray according to the Ottawa ankle rules, then they would be an ESI level 5. Ottawa ankle rules are just a set of validated criteria that some institutions use to determine when x-rays are necessary.
But what about crutch walking? He may go home on crutches. Now, that takes a lot of my time, so shouldn't that count?
As we discussed in the first case, a lot of thought went into what does and what does not count as a resource. If crutch walking counted, then again, we would have at least 2 resources, crutch walking and an x-ray. And we would not be able to distinguish between ESI level 3 and level 4 patients. The use and definitions of resources is what distinguishes ESI and actually makes it work.
So you could really think about it like this. Though crutch walking instructions may consume a fair amount of the emergency department staff members' time, it's often provided to patients who have simple ankle sprains. These patients are typically classified as ESI level 4. The patients are clearly less acute and less resource intensive than more complex patients like those with tibia fibula fractures who are usually ESI level 3. A better way to reflect the ED staff efforts for crutch walking instruction is with a nursing resource intensity measure.
Let's go on to the next case. EMS arrives with a 42-year-old morbidly obese female who called for a chief complaint of shortness of breath. The paramedics found her sitting upright, working hard at breathing, with a respiratory rate of 48 and a room air saturation of 84%. They are unable to obtain any further history. So what do you think of this scenario?
I think she's in acute respiratory distress. She's going to need to be tubed.
So what level would you make her?
Well, she's in severe respiratory distress, so I'd make her a level 2 patient.
Anybody think anything differently?
She's going to need to be a 1. She's going to be intubated.
Okay. So yes, she is an ESI level 1. Sounds like she's in a lot of respiratory distress. She's working hard at breathing. Her room air saturation is 84%. I'm not sure how long she'll be able to breathe on her own. So I would predict she may need either immediate intubation or ventilation with a bag valve mask device.
So her saturation is less than 90%, her respiratory rate is greater than 24, and she's very short of breath. She definitely needs immediate life-saving interventions. You need a physician at the bedside to determine if intubation is needed immediately.
Okay, let's move on to the next case. I have a lump on my back, reports a 28-year-old healthy male. Upon further questioning, he tells you the lump looks like a huge, large pimple. He reports no drainage, no fever. He's got no past medical history. He takes no medications. His vital signs, his temperature is 99.8, heart rate 72, his respiratory rate is 16, and his blood pressure is 118/74. Obviously no life threat or high-risk concerns here, so let's jump to resources. What kind of resources do you think he'll need?
Nothing? It's kind of hard to tell. I can't see it.
Well, you're right, but let's say it's the size of a golf ball. It's really big.
All they're going to do is IND it and then send him home on PO antibiotics.
But does an IND count?
Is that a procedure?
Well, yes it is. It does count as a resource. So what ESI level is this patient?
ESI level 4.
Okay, good. Let's go on to the next case.
Okay, we're going to do something a little bit different. We're going to actually watch a patient scenario here and then kind of talk about it as a group. Sound like a plan? See if I can turn on this video. These are some videos of some patient scenarios that are actual real scenarios here.
Linda Brooks?
That's me.
Have a seat, Linda. My name's Nikki. I'm one of the nurses. I need to ask you a few questions about what brought you here today. You're having some belly pain and bleeding?
Yeah, it's not really pain. It's like cramping up on me, like I have my period. I thought maybe I was pregnant because I skipped a period.
Okay. How long have you had this cramping?
It started about 2 hours ago. I was sitting watching TV and it just came on, kind of sudden.
Okay, on a scale of 0 to 10, with 10 being the worst pain you can imagine, how do you rate this cramping?
About a 5.
All right, and you're bleeding?
It started spotting in the morning and now it's like a heavy period.
Have you passed any clots?
No,
When was your last normal menstrual period?
it's been a while. Let me see, maybe 7 or 8 weeks ago?
Have you ever been pregnant?
No,
Okay. Any dizziness?
no,
Okay, good. How old are you?
23.
Any medical problems you see a doctor regularly for?
No, I'm real healthy.
All right, do you take any medications?
Nope,
Any allergies to any medications?
no.
All right. I just need to take your blood pressure and put this thing on your finger.
Lower abdominal pain with vaginal bleeding is a common chief complaint in women of childbearing age. The cause can range from an ectopic pregnancy to a spontaneous abortion to an irregular menses. In order to decide the acuity level, it is important to look at the patient. This healthy 23-year-old female does not require immediate life-saving interventions, so she does not meet criteria for ESI level 1. The question becomes, does she meet criteria for ESI level 2? And the answer is no. She is awake, alert, oriented. Her pain is 5/10, and her abdominal cramping is generalized, lower abdominal pain. Her skin is warm and dry, and she has experienced no dizziness. No indication that she has an ectopic pregnancy. The triage nurse feels comfortable that she is stable to wait in the waiting room. So moving on to resources. This patient will consume a number of resources. She will need labs, an IV with fluids, an ultrasound, and perhaps IV pain medication, 2 or more resources. So she will be assigned ESI level 3 after the nurse looks at the patient's vital signs and notes they are within normal limits. If the patient's vital signs fell outside the accepted parameter for this age, in this case a heart rate greater than 100 or a respiratory rate greater than 20, she could up-triage her to ESI level 2. If she was hypotensive or significantly tachycardic or had impaired mental status or was hemorrhaging that necessitated the need for immediate hemodynamic interventions like fluid resuscitation or blood, she would meet criteria for ESI level 1. This is a good time to talk about the patient who presents with abdominal pain. Most patients with abdominal pain will be at least ESI level 3, consume many resources, labs, IV with fluids, IV medications, and a CAT scan. The elderly, patients in severe pain, or abnormal vital signs would meet ESI level 2 criteria. The need for hemodynamic interventions would make an abdominal pain ESI level 1, requiring immediate life-saving interventions. Okay, so let's stop and talk about that for a little bit. Do you guys have any questions about this scenario?
Mr. Humphrey?
Oops, didn't quite get that off. Any questions about that one? What do you think?
Pretty straightforward.
Yeah, I thought it was pretty typical of the patients that present an RED and the types of things you assess, the types of common interventions.
And her color looked good. She was fairly animated. She even smiled in conversation with the nurse. So, and she didn't have any unilateral pain or anything indicative of an ectopic. So I'd feel comfortable that even if she's pregnant, she's relatively stable.
We get a lot of patients asking about that ectopic, or a lot of nurses asking about that. They want to make that complaint at a level 2 because of an ectopic. But she really doesn't. I think you said, go ahead.
Right, I was going to say she looked too good. I mean, her pain level was low, she interacted well, her color was good.
And her vital signs were certainly appropriate.
Yep, generalized abdominal pain, as you said, not localized abdominal pain. So good.
Sounds like you guys got it.
Yeah, we agree that it was a level 3.
Oh, good.
Okay, should we do another one? Sure. Okay, let's see if we can turn this on again.
Mr. Humphrey, my name's Nikki. I'm one of the nurses here in the emergency department. I need to ask you a few questions about what brought you here today.
Okay,
I understand you're having trouble passing your water.
that's right. I try to pee, but I only dribble a little. I feel full, like I have to go and can't. My doctor told me to come in
When was the last time you were able to pass your water normally?
about 10 a.m.,
All right. Have you noticed any burning?
a little.
Any blood?
No,
All right. Had a fever, chills?
nope.
All right. On a scale of 0 to 10, with 10 being the worst pain you can imagine, how would you rate this discomfort?
Maybe a 4.
Okay. Do you see a doctor regularly for anything? High blood pressure, heart disease, cancer, diabetes?
No, I'm as healthy as a horse.
All right. Do you take any medicines regularly?
Just an aspirin a day.
All right. Any allergies to anything?
No.
Okay, good.
As you look at this patient, it is clear he does not meet criteria for ESI level 1. He presents to the emergency department with the inability to urinate for about 4.5 hours, probably due to benign prostatic hypertrophy. He looks comfortable. He is able to sit in the chair and calmly give his history to the triage nurse, and he rates his level of discomfort as 4 over 10. So he does not meet the criteria for ESI level 2. If, while waiting, his discomfort increased significantly, he could always be up-triaged. Remember, the patient in severe distress due to urinary retention would be pacing, probably tachycardic, unable to sit still, and verbalizing to the triage nurse that he is miserable. If this patient looked miserable, he would have been assigned ESI level 2 due to distress. So let's move on to the next step in the algorithm. The triage nurse then answers the question, how many different resources will this patient consume? A patient with urinary retention will need a urethral catheter, a urinalysis, and perhaps a urine culture. 2 resources, a procedure plus a lab. The patient's vital signs are within normal limits, so this patient is an ESI level 3.
So what do you think? Do you agree? ESI level 3?
Sure.
I thought it was very clear cut. I mean, it's a very uncomplicated patient and pretty straightforward, not in a lot of distress.
Exactly. He was able to sit there. I think that particular segment showed that very well.
Right. But he'll need procedures and labs, so it'll take some time.
So the resource piece was clear.
Now, when you say labs, are you saying blood work too?
Well, certainly urinalysis,
Yeah.
because he could have an infection too. Sometimes that's a urinary tract infection.
That's a good point, but remember, lab doesn't matter whether it's blood,
that's right.
urine, or stool.
Correct.
It's still one resource. So his resources were a urethral catheter and lab, 2. He's an ESI level 3. Okay, let's move on to the next case.
Okay, now we have a 45-year-old male brought to triage by his friend who states the patient injured his left shoulder while playing football. Patient has a gross deformity to his shoulder and he has neurovascular deficits to his left arm. He's unable to move his arm and is complaining of excruciating pain, 20/10, and he's diaphoretic. So what do you think is going on with this scenario?
I think he's a level 2. He's in severe pain or distress, and I can't really do anything with him in triage.
Good. There's probably another reason that you could make him a level 2.
Is it because of his neurovascular deficits?
Absolutely. Now, are all dislocated shoulders level 2?
Probably not. It probably depends on how they look, how severe their pain is.
Great. So what if he did look pretty good, wasn't in a lot of pain, and had good neurovascular status?
Well, he'll just need an x-ray, so a level 4?
Well, probably not. He is still going to require IV medications to relocate that shoulder, and he's still going to need x-rays. So at a minimum, dislocated shoulders are at least ESI level 3. And remember, conscious sedation as a procedure counts as 2 resources. Okay, next case. Mom brings in her 4-year-old son with a chief complaint of a red arm. The patient was bitten by the family dog about 3 days ago, and the child's kind of cranky. His right arm is red with some edema to a large area surrounding the dog bite. His temperature's 99.5, heart rate's 120, respirations are 24. So, any level 1 or 2 criteria being met here?
No, I think he's an ESI level 3.
Okay, how come?
He needs labs and IV antibiotics, and he probably has cellulitis.
What about his vital signs? Should you upgrade him based on these?
Probably not. He is within the normal vital sign criteria.
Great. This case demonstrates how important it is to always check extremities and visually assess the area of chief complaint whenever possible. If he had a decreased pulse or compartment syndrome, he may even be an ESI level 2. But good, this patient is ESI level 3.
Next case. A 70-year-old male arrives by ambulance from the nursing home. The nursing home reports a non-productive cough since he choked on his lunch today. His baseline mental status is unchanged, and he's normally confused. His skin is warm and moist. His vital signs are the following: temperature 100.2, heart rate 94, blood pressure 135/80, and his room air saturation is 94%. His respiratory rate is 20 and non-labored. So do I hear ESI level 1 for this patient?
I don't know. I don't think he needs to be intubated right now.
Good, neither do I. You know, he really is not in acute respiratory distress. But what about his mental status? Does he meet ESI level 1 criteria for this?
I don't think so.
Okay, why not?
Well, because he's not unresponsive. He's just confused. So maybe he meets a level 2 criteria.
So what do the rest of you think? ESI level 2?
Not really. He's always confused, so it's nothing new.
What about severe distress or high risk? Do you think this is a high-risk situation? Would you give this patient your last open bed?
Well, he comes in by ambulance, and I really don't want him in the waiting room.
Nor do I, but all patients that arrive by ambulance are categorized as ESI level 1 or 2, only if they meet the criteria. So when you think about it, this patient does not meet level 1 or 2 criteria, and his vital signs are within normal limits. He does not violate any vital sign criteria. So he's actually an ESI level 3. He will definitely require 2 or more resources. You know, labs, x-ray, IV antibiotics. He most likely has pneumonia.
But you can still facilitate placement in a bed. But this case does illustrate a really important point. Placement and triage category are sometimes 2 different things. There are some level 3 patients that can go directly to a room, but others can actually wait for the triage process. Okay, next case. Now we have a 5-year-old that is carried in by her father, who reports that the daughter was trying to help set the dinner table and broke a glass. So you notice a 3-centimeter laceration on her left hand. The bleeding is controlled, and the child has no medical history, takes no medications, and has no allergies. And her vitals are normal. So what do you think is going on here?
This is easy. Just a laceration, one resource, a laceration repair.
Okay, good. What if this was a 3-year-old who was screaming bloody murder?
Are you thinking conscious sedation?
Absolutely. So if that was the case, how many resources would the patient consume, and how would that change your triage category?
Well, conscious sedation is 2 resources, plus they would use IV meds. So that makes the patient a level 3.
Absolutely. So what if wound glue was sufficient?
That would be great. Does wound glue count as a resource?
No, it does not. So if wound glue is sufficient and it doesn't count as a resource, this patient would be ESI level 5.
EMS arrives with a 49-year-old male with a history of cirrhosis and hepatitis C. His wife called 911 when he started vomiting bright red blood. On arrival, he's pale, diaphoretic, he has a blood pressure of 92/78, his heart rate's 130, and his respiratory rate is 28. So what do you think of this case? Does he meet ESI level 1 or 2 criteria?
Maybe. He is a little hypotensive.
And he's also tachycardic and tachypnic.
So are you thinking ESI level 1 or 2?
Well, I think it can go either way.
Okay, think about his history. What is he at risk for?
Well, he could bleed out from his varices.
Okay, but what immediate life-saving interventions does he need?
He needs a couple of lines for fluid and blood. So I guess he's a 1.
Right. He's hypotensive, tachycardic, tachypnic, he's pale, and he's vomiting blood. He needs immediate IV access and possibly O-negative blood and at least a fluid bolus.
Okay, let's go back and watch some more video cases here.
I have an awful headache. I can't stand the pain. I've had headaches before, but not like this one.
You look really miserable. You know, on a scale of 0 to 10, if 10 was the worst pain you could ever imagine, how would you rate it right now?
A 10 plus. I can't stand it.
Okay, when did this start?
Today, about an hour ago, I went to the bathroom, I moved my bowels, and it started right after that.
Okay, are you having any nausea or vomiting?
I feel sick to my stomach. Can't you give me something for the pain?
No, not right now. You're going to see the doctor in a few minutes. So first I need to ask you a couple more questions and get your blood pressure, okay? How old are you?
35.
Okay. And do you have any medical problems?
No.
Okay. Do you take any medications every day for any reason?
No.
Okay. And do you have any allergies to medications?
No.
Okay.
This is an ESI level 2. This patient has a new onset, severe headache that is a typical presentation for a subarachnoid hemorrhage. This is a high-risk situation. Headaches are frequent complaints and are worthy of a little further discussion. Patients that present with their typical migraine headache are often triaged as ESI level 3. They usually require an IV with fluid and IV pain medication. However, migraine patients that know they only require an IM selective serotonin agonist and anti-migraine medicine will require only one resource, an IM medication, and therefore will be classified as ESI level 4. Even a patient with a typical migraine that presents in severe pain, vomiting at triage, even though it is a typical headache, could be triaged as ESI level 2 due to severe pain. To summarize, with headaches, history is important to rule out a high-risk situation. Then you really need to assess how the patient looks, and finally, how many resources you might anticipate will be needed. In this particular scenario, the patient met ESI level 2 criteria.
Okay, so headaches are kind of messy and gray sometimes. So what did you guys think about that scenario?
Well, I think that scenario opened my eyes to how I treat headaches, and especially with people with migraines, because you usually think, well, you know, it's just a headache, so you don't really think much about the bleeding or like a possible tumor or something. But I do agree with that level that she should be a 2 because of her. I think the reason why that was a 2 was mainly because of her pain and her instability that way. Am I correct?
I think the connection with the bowel movement was really important too. And
was.
she looked so awful
Yes, she did.
too.
Yeah.
Although some migraine people do, but the bowel movement connection was important, I think.
Definitely that valsalva, having bowel movement.
Right.
Certainly a tip-off that this could be a
Precipitating
subarachnoid bleed.
factor.
Good.
That's what put her over the edge. Any other headache kind of questions?
No, just the worst headache I've ever had in my
Right.
life. Do
That
you up
being
the
a
acuity
tip-off.
for that statement?
Worst headache of their life, usually once they say that, it's pretty tough to not make them a level 2 patient.
Right.
Even in a migraine person who has frequent migraines.
If it's their worst migraine and worse than their normal migraine, then it's not their typical migraine, then I probably would.
I would too.
Still
Absolutely.
go
Although they
Exactly.
sometimes say that because they want pain medication fast, I think.
Well, but you have to take them at their word when you're triaging them.
Exactly.
Sure. Okay.
All right, next case. Patient comes into triage and tells you, I had my appendix out last week and my incision is all red and it's opened up and I've got this yellow gross stuff coming out of my incision. This is a 19-year-old male who has no medical history, takes no medications, and he tells you he's allergic to penicillin. His temperature is 101.8, his heart rate is 98, and his respirations are 16. SpO2 is fine. So, what do you think of this case? Does he meet any level 1 or 2 criteria?
No.
I think he's a level 3. He's going to need lab work and also to be put on IV antibiotics.
So nobody wants to give him your last open bed? He's draining all this yellow stuff.
So,
Okay, I was just checking. So you're right, he's going to require at least 2 resources. Patients who are post-op usually end up being at least an ESI level 3. So let's talk about vital signs. Does he violate any of those parameters?
I don't think so.
Okay, go ahead and check your sheets with the algorithm. It's always good to keep these at triage. After you're really comfortable with ESI, you really won't need to use them anymore. But it's always good to have them out there. There are always people who are new to triage.
So in this case, his vital signs are within normal limits, so we can still keep him as a level 3 patient.
Great, absolutely. Okay, so let's move on to the next case.
Well, why don't we watch another patient scenario? Joe, the police found you lying on the sidewalk. What happened?
Okay. Why can't you just let me alone?
You were here yesterday. What did you do after you left?
I went down to the square and met my buddies. We had a few. And the next thing you know, I'm here.
Okay. So you were drinking? I noticed you had this bruise and this little cut on your face. Did you fall? Did you get into a fight?
I don't know. I can't remember.
All right, Joe, what's your date of birth?
January 22nd, 1951,
All right, what month is it right now?
September.
No, Joe, it's April. Where are you right now?
The hospital. Brigham and Women's Hospital.
Okay. I need to take your blood pressure and your temperature and put this on your finger.
This patient appears to be known to the emergency department staff. He was found on the sidewalk and brought in by the police. He has bruises on his face and a small laceration. His Glasgow coma score is 14, and he is disoriented to time. Joe does not need immediate life-saving interventions, so he is not an ESI level 1. But his presentation is concerning. He has visible signs of trauma to the head, and he has no recollection of what happened and obvious alcohol consumption. He meets the criteria for ESI level 2. His presentation is high risk, and he is disoriented to time. Patients who are well known to an emergency department are often high risk, and it is important not to minimize their presentation. A triage nurse should always maintain a high index of suspicion with well-known patients to the emergency department, especially when they present with substance abuse, any signs of trauma, or a language barrier. This patient meets ESI level 2 criteria.
Tell me something. Do you see patients like Joe?
Sure.
Do you agree he's high risk?
Definitely.
And we need to be very careful with these type of patients. Do you have any questions about that case?
No, but it's interesting. That's where, with people who are drunk or repeat visitors, that's where I see mistakes. In my years in the ED, that's where I've seen the most mistakes in triaging patients.
That's really easy to do. You see
Right.
these people every day, sometimes several times a day.
Sure.
And it's very hard to keep that high index of suspicion up, but you're right,
It's
that's
true.
when bad things happen.
I've seen a heart attack and a couple of other things that were missed, both by the pre-hospital personnel and by us.
Easy for these people to have bad head injuries.
Exactly.
Exactly.
And we need to assume at this point that he had one of those and that alcohol was just another factor. So he is definitely an ESI level 2.
Now, what would happen if we couldn't wake him up? Like if you shook him and he just wasn't responding to you, or it took a painful stimuli, would that change his category at all?
Depends if he was handling his airway and everything. I don't know.
Right, if he's unresponsive, you're right, he becomes an airway issue, which could bump him up to level 1.
Absolutely, that would definitely bump him up to a level 1.
Okay.
He would need immediate life-saving interventions. He would need to be intubated. He cannot protect his own airway. So remember that definition of ESI level 1. Right.
Okay, let's do another case. Robert Douglas?
That's me.
Hi, Robert. Come on in. My name's Paul. I'm one of the nurses. Why don't you have a seat? I'm going to ask you a couple questions about what brought you in here today.
Okay.
So what's going on? What brought you in here?
Oh, just feeling weak. Have no energy. Had trouble getting out of bed this morning.
Okay. When did all this start?
Last night, I was supposed to go to dialysis this morning, but I just didn't have any energy.
Okay, so you were feeling fine yesterday, and today you're feeling really weak.
Yes.
Okay, I'm going to go ahead and get your blood pressure. How old are you, Robert?
62.
Okay. Are you having any pain or problems breathing with this?
No, just feeling dizzy.
Okay, so you're feeling dizzy. Do you have a list of medications that you take?
Yes.
I think it might be right there.
Yeah.
Great, thanks. Okay, so other than the renal failure and the hypertension, do you have any other medical problems that we should know about?
Well, I've had 2 heart attacks.
Okay,
I had bypass surgery in 2002.
okay. When was your last dialysis?
3 days ago. I've got one of those catheters.
Quentin catheter?
Yes.
Okay.
Yes.
Another interesting patient. He does not need to be immediately rushed back to the treatment area. He does not require immediate life-saving interventions. He is not an ESI level 1. However, he is a high-risk patient. The concern is his significant medical history that includes chronic renal failure, hypertension, and significant cardiac disease, combined with his presenting complaint of feeling weak. There are several questions the triage nurse cannot answer at triage. Is his potassium markedly elevated? Is he having another MI? What does his EKG look like? These are major concerns that warrant assigning this patient to ESI level 2. He is high risk, and it would not be safe for him to wait in the waiting room. I would give him my last bed. This patient meets the criteria for ESI level 2.
So, Jenna, do you think he looks a little bit too good to be this dialysis patient and given him a level 2?
What do you mean by too good?
Well, does he look pretty okay? He looks pretty good to me, really.
Well, except that you have to consider he's chronically ill. So, you know, a lot of what he's experienced before. So, you know, it may be usual to him in some ways. I mean, one thing that came to me right away, I don't think they do it in that ER that they were showing there, but we do EKGs in our triage area. That would be something he could get in our triage area that would right away tell you if there was anything going on cardiac at that moment.
Okay, but would you get an EKG before you assign a triage category? Or would the triage category kind of dictate the fact that you need to get that EKG?
Well, yeah, you'd go ahead and assign him a category. However, as an adjunct along with all the other information you're gathering, an EKG could be part of that.
Right. And that's a good point, because a lot of people are doing more and more at triage now. But I think you still are going to have to make a decision on the triage category before you have any other interventions or do anything else. And I think he just looks pretty good, but it's important to remember he's high risk, he's due for that dialysis patient, and all those things that we talked about. He's dizzy, he's having chest pain. You really don't have any idea.
Right.
So if you did his EKG, then that's sort of a process thing afterwards. But you're still not going to know his potassium
Right,
level, so
right.
I wouldn't
I mean,
still
he still
change him.
needs a bed.
Don't you see all these patients with weakness coming in with that chief complaint? And I think the thing the triage nurse has to do is sort out what are the, what I will call high-risk situations. You know, is he a diabetic? I mean, this particular gentleman told you he was a renal patient, but you know, what is his history? It could be so many different things, and many of these are high-risk patients because they have chronic medical problems.
And many of them don't have the classic symptoms, even if they're having a heart attack. If they've had an incision in their chest or if they're diabetic, sometimes they won't have classic chest pain as a presenting complaint.
That's an excellent point.
And in a lot of ways, you know, I consider it like a puzzle. I mean, he starts out with the dizzy weakness part. Well, then he adds the dialysis part, then he adds a hypertension part, then he had 2 MIs, and you're like adding all these pieces to the puzzle, and they're giving you a picture.
And because of that history, especially, I would make a room for him. I know you mentioned on the video that you would give him your last bed, but even if the bed was not available, I would have to pull somebody that was more stable and put him in before I do that, because he's weak. I saw him walking with a cane to you. I would go ahead and get a wheelchair or a stretcher to push him back into the treatment area. That's what I would do.
Great.
Excellent points on this case.
Yeah, if he was a level 2, he was very, very like up there and upwards of level 2.
Well, that's a good point too. What if you had 5 level 2s now? What if you had, we could do a little prioritization of 2s. So you have somebody now with, let's put that subarachnoid that we talked about with a headache, female with severe headache after a bowel movement that we're thinking is a subarachnoid. And then you have this patient with dialysis. And then you have somebody who has chest pain and some shortness of breath. So who would you want to put first?
I certainly want to do the EKGs to see if I saw
Right.
anything.
Don't have that at this institution.
have that?
I get
Too
the
bad.
pulse ox on the shortness of breath and pulse ox on the
That's a
dizzy.
good
On
idea.
the dizzy guy.
I mean, that right. I mean, I think what you need to look at is who's requiring intervention immediately. And so that would be one telltale in terms of a life-saving intervention is the pulse ox.
Well, let's say that we have none,
Yeah,
and that's
I'll
absolutely
see
true, no level 1 criteria for any of these patients. So you have 3 level 2s. Chest pain, short of breath, this man who's weak and dizzy on dialysis, and you're maybe subarachnoid.
I'd have a hard time between the chest pain, short of breath, and the subarachnoid.
Gotta have to see him, but
Right.
let's say that, this chest pain doesn't look very good.
Yeah, that's what I was going to say.
Not looking good.
The subarachnoid, we'd want to get her back, but she looked good at that moment.
Right.
But again, we don't have the information on the shorter breath chest pain, but things like how he looked physically. Is he diaphoretic?
Yeah, let's say
What's his
factors.
color like? What's his age group? Any past history? Any factors that are making us think heart?
Right.
I think what Paul is saying, part of it is you're basing your judgment on your across-the-room assessment as well as
Yes.
that information you gathered during your triage assessment. And really figuring out who's the sickest, who really needs to go back first, and who can safely wait for a few minutes until another bed becomes available. In this era of ED overcrowding, finding beds is becoming increasingly more difficult. And I really liked your point about pulling somebody out of a room
Right.
into the hallway and creating a bed.
Yes.
Because you're going to face this situation all the time. And you still do that, and people ask us that question a lot too. So just because you have 5 levels, within those levels you're still going to have to prioritize your 2s, and you're still going to have to prioritize your 3s. So time ordering your chart according to category is just not a good idea. So you're still going to have to do a lot of assessment. Great.
So let's do the next case. You're notified by EMS that you're receiving an 8-year-old female who was struck by a bus while crossing the street. Bystanders report she was thrown across the street. Her initial vital signs, her heart rate was 148, respiratory rate 36, her blood pressure 70 over palpable, and her room air saturation 91%. So does this patient meet ESI level 1 or 2 criteria?
Probably.
Probably what? ESI level 1 or 2?
Well, I want her in the trauma room. She's a bad pediatric trauma. I think she's hypotensive and tachycardic for her age.
So level 1 or 2?
I think level 1.
Okay. Great. She is hypotensive, and she does require immediate life-saving interventions. What specifically do you think she'll need?
Well, lines for fluid resuscitation, a fluid bolus, possibly blood, possibly intubation, depending upon what they find.
Perfect. You aren't just starting a line to have a line. She needs immediate life-saving interventions. She needs hemodynamic resuscitation. Now let's talk about this. What if this were an adult with the same vital signs, same scenario?
I don't think it would change anything.
You're right. Just checking. Let's move on.
Okay, next case. We have a 33-year-old that comes to triage from her doctor's office. She complains of a severe frontal headache, 10 over 10, for about 4 days. She went to her eye doctor's office because she thought she needed glasses. The ophthalmologist performed an eye exam and sent her directly to the emergency department for further evaluation. She's alert oriented times 3. Her blood pressure is 260 over 160. Her heart rate's 82, and her respirations are 16. SpO2 and her temperature are fine. So, what do you not like the most about this case?
Well, the blood pressure is off the charts.
So how does this work if the blood pressure isn't part of the vital signs criteria for the ESI?
That's a good question. All patients probably should get vitals, especially adults who are going to go to the waiting room. This is a perfect case that demonstrates the need for vitals.
While it's true that vitals are usually not helpful, a patient with a headache or a nosebleed are really 2 examples when you need to take the blood pressure. Make sure you check it. So let's go back to this case. What do you think the ophthalmologist saw, and why did he refer her to the emergency department?
Well, maybe she had papilledema, and then I guess he checked her blood pressure.
Great. So what triage level is this patient?
Well, she's tolerated this pressure for 4 days, so I would make her a level 2. She is high risk.
Could she be a level 1?
Well, does she require immediate life-saving interventions? I would err on the cautious side with this case. She is going to require immediate access for medication administration to start lowering that blood pressure. While it is true she may have had this elevated blood pressure for 4 days, you don't know that for sure. It may have just started today. It's really hard to tell.
Well, I would make her an ESI level 1 and get her care going. 260 over 160 is really high. She is symptomatic, and you can bet she has papilledema. She has the potential for a stroke. What if she was, symptom-free, and this was a by-chance blood pressure? She came in for a minor unrelated complaint.
I guess you could make her a level 2 or a level 3.
I wouldn't make her a level 3 though. She's too high risk with that high of a blood pressure, even if she is stable.
Agreed. Okay, time to move on.
Okay, now we have a case. You're notified by EMS that you're receiving a 78-year-old male who collapsed in the garden. His daughter called 911 and immediately started CPR. He was defibrillated 3 times in the field, and he was brought into the emergency department in sinus bradycardia, and his pressure was 88 systolic. So what do you want to do with this gentleman?
ESI level 1. He's post-arrest and will require continuation of the resuscitation. He's also going to be going on a vent and will need drugs.
Absolutely. He's still hypotensive, he's bradycardic, and he's going to need some IV vasopressors, probably dopamine. He may deteriorate back into VFib for all we know, so he is definitely a level 1, and there is really not much more to say about that.
Let's do the next case. A 14-year-old male is brought to the emergency department by his mother, who tells you she is concerned her son has poison ivy. He was doing some yard work for a neighbor and 2 days later developed itching, redness, and little blisters on his arms. She is concerned that he will spread it to the whole family. He's healthy, takes no medications, has normal vital signs. Okay, do you think he meets level 1 or level 2 criteria?
No way, they need to go home. They should have gone to see their doctor.
Okay, so maybe home after some great patient education. So are you saying this patient is not going to require any resources?
Right, he is an ESI level 5. He's going to be instructed to go home to get some over-the-counter medicine.
That's right. Don't forget, this is a really good opportunity for patient education. Why don't we watch another vignette? Larry, why don't you have a seat? My name's Nikki. I'm one of the nurses, and I need to ask you a few questions about what brought you to the emergency department today. I also need to take your blood pressure and put this thing on your finger.
My wife brought me to the emergency department. She's all worried. She thinks I'm having a heart attack because I have this pain. It's not really pain, more like a pressure, like something sitting on my chest.
Okay, do you have this pressure right now?
Yeah.
All right. Now, do you have any medical problems that you see a doctor regularly for?
Just my high cholesterol. But he put me on a medication, an anti-cholesterol drug. It's much better now.
What were you doing when this pressure started?
Sleeping. Woke me right up. Hasn't gone away.
All right. What time was that?
About 6 a.m.
6 o'clock. Do you feel short of breath at all?
Kinda.
All right. How about your stomach? Do you feel sick to your stomach?
A little queasy.
A little queasy. All right. I need a wheelchair to triage, and I'm going to be taking that last monitored bed. Larry, how old are you?
52.
52. I have a wheelchair and then I'm going to have you have a seat in, and your wife can go ahead and get you registered into the emergency department.
This 52-year-old male has multiple risk factors for cardiac disease: obesity, smoking, and high cholesterol. He presents to the emergency department with chest pressure that woke him up from sleep, with nausea, shortness of breath, and diaphoresis. His heart rate is between 30 and 40 and irregular. His respiratory rate is rapid, and his blood pressure is low, 90/76. This patient is probably having an acute MI. He needs to be seen immediately and immediate life-saving interventions initiated. He needs IV access, fluid, pacing pads in place, and other hemodynamic interventions. He meets criteria for ESI level 1.
Interesting case. What do you think? Do you agree, ESI level 1?
Oh, absolutely.
Yes.
Definitely.
He may not agree. The patient may not agree.
But, you know,
Right.
the denial is
Yes.
along with the diagnosis.
Oh, that's an excellent point. Did you notice how diaphoretic he was?
Yes.
That was one of the first things I noticed.
Yes, that across this room assessment really
Right.
made you key in on that. He had so many risk factors. Now, why didn't I just walk him back to to a treatment room?
Because activity increases his myocardial oxygen demand. So you would want him to rest and get oxygen in.
That's an excellent point. We really need to do that.
He's also bradycardic, and I think he was also had hypotension. His blood pressure was low too, so
Yes.
that's another red flag.
Great, and that's really the thing that makes him a level 1 versus a 2, because you really don't want to make all of your chest pains level 2. If you start making all your chest pains level 2, then people really aren't going to be paying attention to level 1s. He was a level 1 because he was bradycardic. Most chest pains the nurse can manage just fine for the first 10-15 minutes. You put him on the monitor, you get your access, you get your labs, you get your EKG, and you really don't need a physician at the bedside. This patient who's that bradycardic and hypotensive, you want to bring the doc to the bedside because you may start doing more than those things. The things we talked about, the pacer pads, all of that is really good. Still, with all that, he looks pretty good. And I know I would have been surprised when I found his heart rate was 30. I would not have originally pictured that I would have been making him
Right.
level 1. That was the one thing that would have made me change my mind.
Especially since he brought in that can of soda. He was pretty active.
He had
still.
so many risk factors, and it's true. ESI level 1. My concern would be getting him back into that resuscitation room before he arrested. So,
Exactly.
Me too.
yeah, good. Why don't we watch another patient scenario?
Louise Wood?
Yes.
Hi, come on in, Louise. You okay there? Should have a seat. My name is Paula. I'm going to ask you a couple questions about what brought you in here today and get your blood pressure, okay?
Okay. I feel really silly being here, but the girls where I work insisted that I come over and get checked out.
So what's going on?
I have this pain. It's like a constant pressure. It's not like my heartburn. This makes me sick to my stomach.
How long has this been going on?
About 3 hours.
Okay. Have you taken anything for it?
One of my coworkers gave me an antacid. It didn't do anything. I'm just so tired.
Okay. I'm going to get your blood pressure and ask you a couple more questions. How old are you?
57.
Okay. And on a scale of 0 to 10, with 10 being the worst pain that you can imagine, how would you rate that pain right now?
About a 7.
Okay. And do you,
Nurse, this isn't going to take long, is it? Because I've got to get back to work. I've got so much work to do.
I can't tell you exactly how long it's going to take, but it is really important that you see the doctor today.
Okay.
Okay. Do you have any medical problems?
I have high cholesterol, and I've had some heartburn lately.
Okay. Do you take any medicines every day on a regular basis?
Yes, it's here in my purse.
Okay. Can I see? Great. Thanks.
This 57-year-old female presents to the emergency department with epigastric area pressure. She has a history of high cholesterol and seems to be stressed about work, all risk factors for cardiac disease. We know from the research that women with heart disease do not present with the classic signs of chest pain and shortness of breath. Usually their discomfort is more upper GI, and many will complain of being tired. This patient is currently stable and does not require immediate life-saving interventions, but she is high risk for cardiac disease. She meets the criteria for ESI level 2. If her blood pressure was low, or her heart rate was high, low, or irregular, and her skin was cool and diaphoretic, she would then be an ESI level 1. This patient is currently ESI level 2. Interesting woman. What do you think? Do you agree with that?
Yes, that really makes sense.
Women are different, aren't they?
Yes. One of the first things I noticed about her is that she was very short of breath, and that kind of alarmed me. He said the whole time that she was talking to you, that was what I was thinking about. Okay, that she's short of breath. You know, I need to try to help.
You needed
give
to
her
do
some
something
yes,
to intervene
soon.
Even if she was just being dramatic,
Right.
which, obviously in an emergency department we have patients who present that way. Would that change your priority rating at all? Would you still make her a 2?
I would, and I was considering the question of whether she was hysterical and nervous or whether she was actually short of breath. The other thing is that she did take an antacid and it didn't help at all, which leans me still further in the direction of a possible cardiac condition.
That's an excellent point. Now, women with heart disease, they tend to deny their pain. We know that. There's a lot of things we're learning in the last 10 years about women and how they present to the emergency department. We need to make sure that they get seen. Does anybody have any other questions about this particular patient? Anything they want to say?
No, her vital signs were normal.
They were. Her
still,
blood pressure,
it
heart
doesn't
rate,
mean-
everything. She just, as you said, was a little tachypnic.
And I didn't see her pulse ox. What was that?
I believe it was 100%. It was normal.
Because I thought the
Yeah.
shortness of breath was quite evident.
Good.
I wanted to give her an emesis basin.
Well, that's a good point.
Had so much epigastric distress. Just watching the video, I was concerned. And that bothered me a lot too. But we really tend to blow off women, and even in some of the teaching that we do, we still find a lot of nurses that don't want to take females seriously with this kind of chief complaint. And it's kind of surprising, but still there are people that want to minimize women with epigastric distress, and it's not something that you want to do.
They make
She's
it
high
easy.
risk.
They're so vague in their
Right,
complaints.
they are vague.
We're so vague in how we speak about our complaints. We tell too much.
What would she have to look like to make her a level 1?
Well, some instability in the vital signs.
What if I said her heart rate was 180?
Oh, yeah.
Then she'd go up.
Yeah,
Definitely.
definitely.
If her color looked worse as well, if she had diaphoresis as well as the epigastric distress and the shortness of breath.
Either hypotension or hypertension, either one.
Good. Interesting case. I think we learned a lot from that one.
That's good.
Okay, let's do a suicidal scenario. Okay, we have a 21-year-old female who comes in with her parents who said that her daughter expressed suicidal ideation after the boyfriend broke up with her. The patient denies being suicidal. She's alert, she's oriented ×3, and she's a little bit non-cooperative. Her vitals are 97.9, 82, 20, and 115/70. She is requesting to leave. After all, she says she is 21 years old. So, with everything you know about this scenario, what triage level is she?
I know she's considered high risk and an ESI level 2, but I just don't get it. Why is she given such a high priority?
Well, that's a concern that many ED nurses have. So let's just go ahead and talk about it because we have a lot of these patients. This patient cannot be trusted. We must assume she's suicidal, therefore she is high risk. If she were to leave and kill herself, you and the hospital would be liable.
You know, she may not get to your next bed, but this case really illustrates process and triage categorization subtleties. Some institutions will have a place for these patients. Others have protocols that require the triage nurse to immediately call for a standby or for somebody to observe her and possibly notify a crisis worker or a psychiatric liaison.
And other institutions may draw labs for medical clearance. So we are actually doing quite a bit for these patients on arrival. But the bottom line is she is high risk and take credit for it. Don't sweat it. Suicidal, homicidal, and psychotic patients are very high risk. We now have a 76-year-old female that tells you that she feels like she's going to pass out. She says, you know, I've been feeling weak and dizzy ever since I got up this morning, and I don't usually feel like that. I usually feel fine. I'm really healthy, and I don't even complain at all. Her SpO2 is 96, her heart rate is 32. So what do you think about her? A little weak and dizzy. Gee, that's something that we never see.
I think she's a level 1.
How come? What kind of interventions does she need?
Well, first off, she's bradycardic. And I don't know what her blood pressure is, but she is dizzy and weak. So most likely she could be hypotensive. So she needs an IV line, possibly some atropine, and at least external pacer pads applied.
Right. If her BP is okay, I just leave the pads on and go for IV access. But if she's hypotensive, she may need immediate external pacing.
Perfect. She definitely is a level 1 patient. She needs immediate hemodynamic interventions.
I think it's time for a pediatric case. All right, here we go. Parents rush into the emergency department with their 11-month-old child. He has a temperature of 103.8, reports the mom. He woke up from his nap cranky, and he keeps pulling on his left ear. The baby is sitting quietly on the mother's lap, sucking on a bottle of juice. He cries when you try to listen to his heart. His temperature is 102.6. His respiratory rate is 30. His heart rate is 128. His room air saturation is 100%. So what do you think? Is he high risk?
I hate triaging the kids. I just don't feel comfortable.
Oh, we see kids all the time. This kid's fine.
Well, how do you know that?
Well, look at him. He's sitting there, sucking down juice. He looks great.
But he's got a fever of 102.6.
But an antipyretic will take care of that.
Let's look at the algorithm. Under Decision Point D, there's a section under Vital Signs that discusses PEDS fever criteria. There's actually a lot of very good literature on this topic. If we go through the guidelines that are evidence-based, we'll see that if this child was less than 28 days of age, no matter how good he looked, he'd be at risk for a serious infection, and therefore would be at least an ESI level 2. If he looked flaccid or lethargic, he'd be an ESI level 1.
So moving up in the age group, there is some controversy over how to manage a fever in the 28-day to 3-month-old. So depending on your institutional practice, you could make a child in this age group a level 2 or 3. Finally, the 3 to 36-month-old child, the child in our scenario, will probably be triaged as ESI level 5. In this age group, the triage nurse first considers fevers greater than 102.2. So you may up triage for this high of a fever.
You know, you should also consider if there's an obvious source of infection. This child is tugging on his ear, so there's a probable source of infection. The triage nurse must also ensure that the child is up to date on his immunizations. So this child could actually be an ESI level 5. Again, it's the nurse's judgment. But all babies less than 28 days of age must be, at a minimum, ESI level 2.
Okay, let's go back to the tape and see what other kind of cases we've got on here.
Kristen McKenzie? Come on in, have a seat. My name's Nikki. I'm one of the nurses. I need to ask you a few questions about what brought you here to the emergency department today. I also need to put this on your finger, and we'll take your temperature and your blood pressure.
Okay.
All right. So what brought you here today?
We're here in Boston on vacation. My daughter has a history of asthma. It's not bad, but she needs to use an inhaler when she plays sports. We're heading up north to go skiing, and she forgot her inhaler. I told her to pack it, even put it on the bed next to her suitcase, but she forgot.
Okay, so you're here for a prescription refill?
Yes.
All right. Kristen, how are you feeling? Any shortness of breath? You feel like you're wheezing at all?
No.
Okay, good.
A healthy 10-year-old with a history of asthma presents to the emergency department with her mother requesting a prescription for an inhaler. This child meets ESI level 5 criteria. She needs to be seen by a physician, have a prescription written, and be discharged by the nurse. If she had been wheezing a little, she would need a handheld nebulizer treatment with a pre- and post-peak flow, one resource, making her an ESI level 4. A level 3 asthmatic would be one who required a chest x-ray or labs, additional resources. If this patient was wheezing significantly and in severe distress with a good oxygen saturation, she would be ESI level 2. However, if she was decompensating, tiring, and had an SpO2 less than 90%, and the triage nurse was concerned she would require immediate intervention, she would meet ESI level 1 criteria. So what do you think about that case? Pretty straightforward? What do you think?
Sure.
Okay.
I think the patient looks good. I know we get a lot of patients in the ED that come in because either they ran out of medication or they didn't have it. A lot of times we do see that, and I do agree that this case would be a level 5.
You know, I bet there's probably some nurses out there and some of us that want to kind of read more into the case. But she doesn't have any shortness of breath. She has absolutely no complaints. Another kind of example of the same thing is patients that come in with a different complaint and have a blood pressure that's up. Totally unrelated. So don't make things more than they are. She just wants a prescription refill. That's a 5.
Well, if I was triaging her, she told me she felt fine still, but I would still grab my stethoscope and still listen to her just, in case, because of her history for asthma and because she's in a new area where the altitude or the weather is different. So I'd still be, a little cautious about that.
That's another great point. Can you think of any other patients who would be ESI level 5s?
Well, what about suture removal? That seems very simple. Is that a procedure, removing sutures?
No, we don't count that as a resource.
Oh, okay.
That would be an ESA level 5, definitely. And you were saying?
I was going to say a rash as an example.
Yes. Many of those patients come in, they just want to know what it is. They get a medical exam, and they're perhaps given PO medication and then discharged. Many of the time, often it's discharge instructions. That's really what they need.
What else? A couple more.
What about like adult that comes in with like a common cold because they couldn't sleep in the middle of the night, they're tossing and turning, they have no place else to, they're not going to sleep, so they're going to come in.
Yeah, sure. As long as you don't think they're going to need a lab. If they're going to send a culture or throw culture, then they'd be one resource in level 4. There's a couple more 5s that are pretty common. You think of anything else?
Earaches in children.
That's a good one.
That looks stable.
A wound check.
Wound check is a great one. They come in all the time. Doesn't require any resources, just a physical exam.
Abrasion to the skin, you mean?
That's a very good example.
Yeah,
Like
that's
a
really
small
good.
abrasion.
Or a minor cut that turns out not to need suturing.
Another good one. You know, as I watched this scenario, I felt bad for the mother. You know, here she is on vacation and has to bring her child to the emergency department for a prescription refill. You know, sometimes nurses in the ED really, you know, why are you here? They question that. And, you know, Paula, I think we both agree that, you know, there's nothing we can do about it. These patients, we want to see them and we want to try and streamline them through the department.
And I think it's nice to see a patient where we can offer preventative care for a change. And also, like you said, someone from out of town that's stressed, you know, any patient that comes in, we should look at it as an opportunity for customer service.
Good point.
And I felt kind of sorry for the little girl because I think she's going to hear about this a lot for her vacation, even though it was her fault.
Good point.
Okay, here's a new scenario. Here's a patient with a UTI. So the patient comes in and says, I think I have a UTI. It burns when I go to the bathroom, and I'm going all the time, and I only go a little bit. This is a 19-year-old patient who's had these symptoms for 24 hours. She denies abdominal pain, fever, chills, or any kind of vaginal discharge. She's healthy, no medications, no allergies. Her vital signs are good, 97.8, 80, 16, and 110 over 76. So, do we need a life-saving intervention here?
I don't think so.
Okay, how about high-risk criteria or severe pain or distress?
Not hardly. How about just a urine sample?
It sounds like a good plan. Does anybody think she's going to need anything else?
Well, it depends on which physician is working.
Yeah, I'm so glad you brought that up. You know, ESI is based only on the triage nurse's judgment of how many resources she thinks the patient will require to get the patient to a final disposition, whether that's home, admission, or transfer. This judgment is based on her experience and knowledge of emergency medicine, standards of care, and institutional protocols. Physician practice will vary, but ESI has shown that triage nurses do really well at predicting what patients will need.
And remember, the purpose of predicting resources is only to help assign a triage category to the lower acuity patients. The 3s, the 4s, the 5s. So if the story changes and the patient requires more resources, that's okay. You shouldn't triage differently based on how, who's working, how busy the department is. Okay, so let's go back to the case. Sounds like a urine is all we need. One resource, level 4 patient.
But wait, she's going to need a pregnancy test too. And we don't usually send our urines to the lab. We just dip it and then treat when necessary.
Well, let's talk about the pregnancy test first. Bedside testing, if that's what your institution does, doesn't count as a resource. Adding a pregnancy test doesn't change the number of resources. Lab counts as one resource, regardless of the number of tests you send, or the type of specimen. For example, blood, or urine, or stool.
So this is another great example of some institutional differences that are handled without a problem using ESI. If the case you just discussed, if the urine is never sent to the lab, it is considered a bedside test, does not count as a resource, and the patient is a level 5. If at any point that urine goes to the lab, then we're back to ESI level 4, one resource. Let's do an eye case. So you have a patient who comes in and says, my eyes are just all red and crusty. She's a 19-year-old female. She said she's had red, itchy eyes for 2 days. She has no medical problems. She takes birth control pills, has no allergies. Her vitals are 98.6, 72, 16, and 122 over 76. Her visual acuities are 20/20 in both eyes. So what do you think is going on with this patient?
She probably has conjunctivitis, the red, itchy, goopy eyes.
Absolutely. Now, is that a high-risk situation?
Oh no, it's a very common complaint.
Okay, so now we have to move on to resources. How many resources do you think it's going to take to get this patient out of the emergency department?
Just one, an eye exam.
Okay, and does that count as a resource?
Well,
I looked at
no, I guess not. Why not? It's pretty important.
That's a great question. When ESI was developed, the researchers made some really thoughtful decisions about what does and does not count as a resource. If everything that we did counted as a resource, we wouldn't have any level 4 or 5 patients. Every patient gets a physical exam, so it's decided that physical exam doesn't count.
Let me talk a little bit more about physical exam. The patient who comes in with an eye complaint is going to need a slit lamp exam. That is part of their physical. It would be just like a woman with low abdominal pain. She would require a pelvic exam, and again, that's part of the physical exam of that patient. So, does this patient require any resources?
I guess not.
So, what level is she?
Well, if no resources, then I guess she's an ESI level 5?
Great. So let's talk a little bit more about eye complaints. This patient most likely has conjunctivitis, which is a common complaint in which patients often seek treatment in the emergency department. Most eye complaints often end up being triaged as either ESI level 5 or 2 because they represent a high risk to the loss of eyesight.
Well, in this particular case, and this one's triaged as an ESI level 5. Conjunctivitis is not an acute eye problem that is considered high risk. What's another example of an eye complaint that might be an ESI level 5?
What about someone that comes in complaining of something in their eye but has severe pain?
That's an excellent question. So you have to actually ask 2 questions. First, is this a high-risk situation? And second, do they have severe pain?
Well, it's certainly not high risk. People come in on the ED all the time thinking they have something in their eye, but they have 10 out of 10 pain, so that makes them meet the ESI level 2 criteria.
True, but you could put optane in her eye. The protocol states that in order to be level 2 criteria, you have to have pain of 7 out of 10 or greater, and that you can't do anything about it in triage. So in this case, we could put some topical anesthetic in her eye to make her feel much better. And then, therefore, we can make her a level 5. But if your hospital doesn't have such protocols, then I would make her a level 2 based on severe pain.
Okay, good. Let's talk about some examples of high-risk eye situations. Can you guys think of any?
How about a sudden loss of vision in one eye?
Absolutely. That could be central retinal artery occlusion or retinal detachment. Can you think of some other examples?
Chemical splash?
Definitely. It's safe to assume that most patients with a chemical splash are going to require rapid irrigation. An eye problem that requires irrigation but not necessarily high risk would require one resource, and that would be an ESI level 4 patient. So those are both great examples, but there's one more I'm thinking of. Can you think of something else?
How about trauma to the eye or a foreign body, like a nail?
Absolutely. Patients who have obvious trauma are at risk for a lot of injuries, and obviously foreign bodies are really bad as well. A hyphema is another good example that should be considered ESI level 2. Another example of a patient with an eye complaint that's considered ESI level 5 would be someone with a foreign body sensation and pain to the eye.
Often patients present either with something that blew in their eye or pain from contact lenses. These patients usually have a corneal abrasion and again only require an eye exam. These patients also complain of severe pain. However, if the triage nurse can instill a few drops of topical anesthetic at triage and decrease the pain, then they meet ESI level 5 criteria.
And finally, just as an aside, if possible, it is recommended to obtain visual acuities at triage. This is a really important vital sign for patients with eye complaints, even more so than a temperature, a pulse, and respirations.